Thank you for that generous introduction. So, good afternoon, good evening, everyone. The topic that I'm going to present today is on my work comparing personalized dose in high definition and conventional TDCS for neuropsychiatric disorders. Okay, so I don't have any disclosures to be made. So, whenever we talk about TDCS, one thing always comes in any research is the inter-individual variability. Inter-individual variability in TDCS outcome limits the generalizability of TDCS as any treatment modality in neuropsychiatric disorders. Usually we see this variability because of the inter-individual anatomical variability, as well as different stimulation parameters that we are taking in account. So all of these causes a lot of inter-individual variability. So to tackle this, recent studies has been given that we cannot reduce or change the amount of current that is generating inside the cortex, but we can actually vary the amount of current that is given from outside the scalp. But however, this approach is very good. But there are certain factors that affects this current distribution. And when we are taking this dose-controlled TDCS approach, one of the factors is the montage configuration in the diseased brain, and another one is the atrophy in the diseased brain. So it is known that HD-tDCS is more focal in nature, but it always comes with a trade-off that because of the focality, it has a very high inter-individual variability. And so it always remains a question in front of the clinician when they are deciding which one they have to choose, whether should they go for conventional or the HD. So for that, what we did that, we wanted to question this, which montage is actually more appropriate for disease population. Okay, it's not going up. So to answer this question, what we did, we designed a study in which we took a neuropsychiatric population. Two groups we took. One is a dementia group, another one is depression. And we included healthy volunteers for the comparison. Why we took dementia? Because it significantly shows high atrophy, whereas depression, it's very unlikely to be seen any. What we did, we took two montages that can be used for this population. One was conventional montage, another one was high definition montage. And we wanted to actually see which one results in lower variability. So for that, we placed these montages on two language pathways, dorsal and ventral pathway. The whole reason of choosing a language pathway was because we wanted to, because we know that language pathways are extensive. It has a it's spread in large brain areas, and also it has two roads, so it was easy for us. So let's now talk about the sample distributions and all. So what we took, we took dementia, 50 T1 weighted dementia we took from LASI data set. And depression we took 25, whereas healthy we took 25. Both of them we took from an ongoing psychiatric study that is going on in NIMHANS. And then all these scans were taken to simulate two montage configuration, conventional and high definition, and these were applied for two language pathways, dorsal. For dorsal, we use CP5CZ, and for ventral, we use TP7 nape of the neck. Totaling around 400 simulations were done for the studies. So after the after we place the montages, we get the E-field distribution. It's not working. Okay, we get the E-field distribution for them, and we get simulation for the target ROIs. For dorsal pathway, the two target ROIs that we were concerned with were left inferior parietal lobule and left angular gyrus, whereas for ventral pathway, we were concerned about left middle and inferior temporal gyrus. Now, these were not enough for us. So what we wanted to do is that quantify how much current is actually generated for these ROIs. For that, we to calculate the amount of current at each target region, for individual brain, we use something called as ISATA, which is a MATLAB toolbox, which calculates or estimates the current density across individual ROIs. So from this toolbox, we estimated the average current density at the 4 desired ROIs for 2 montages, that was conventional and HD. ACD values, means the average current density values, then were used to calculate the personalized dosage from the individual dose formula. So if you want to see, this M reference intensity actually is the value that we obtained from a standard MNI template, whereas the M actual intensity is the ACD value that we get from the simulation that we did in ISATA for each particular ROIs. And then to understand how much atrophy is there in the particular scan, what we did, we just used a CAT12 toolbox. We estimated the volume parameters and then calculated the global brain atrophy from this formula. Now, for the to get what we did, we performed a regression model so that we can understand the relation between the personalized dose at each ROI. And so what we did, we took the personalized dose at each ROI as a dependent factor, whereas for independent factor, we took the montage and the patient group. So we saw that there was a significant effect of the montage type as well as the patient group interaction. So if you see this mean standard deviation plot, you can clearly see that that for the conventional dose requires very significantly conventional dose requires very low dosage as compared to the HD electrodes. And interestingly, we saw this for 46% of the population of dementia population that we took, that HD-tDCS of 46% need more than 4 milliampere of dosage. And this was quite interesting finding that we found from this study. We found this result for both angular gyrus and inferior parietal lobule for left and dorsal pathway. We didn't find any such effect in the ventral pathway for both the ROIs. Now, what we wanted to see is that whether there is any relation with the atrophy. So we compared the brain volumes, and if you see that dementia group was highly atrophied as compared to the healthy and the depression group. So at the AST, we wanted to see whether there was any relation between the personalized dose and the atrophy. For that, we did a regression analysis, and if you see the figure 1, we can clearly see that as the atrophy increases, the amount of dose needed by the particular individual will also increase. And figure 2 is, we took the patient group as a cofactor, and we saw that this is a very interesting relation, that if you are using personalized dose in your protocol for TDCS, it is very important to consider the pathophysiology of the neuropsychiatric group that you are taking in account. So for conclusion, what we did find is that the atrophy is very significant to determine of a personalized dose in TDCS. Another thing we found that whenever we are taking an account of any patient brain, we have to consider the pathophysiology before we apply any TDCS protocol on them. And that conventional montage is very good. Like, it's more suitable for an atrophy, cortical atrophy brain, because the dosage is always within the limits and safety of less than 4 milliamperes. So finally, at last, I would like to acknowledge DBT for funding this project and ICMR for the travel grant. And finally, I would like to thank my team for all their confidence and support throughout this project. Thank you so much.
Any questions from the audience? Oh, we have one.
So in the computational model, did you use a white matter pathways to?
Computation model, actually, it's a straightforward. What it does, the first step is the segmentation. So it takes white matter, gray matter at the CSF volume, all of them. So when we are placing the electrode, manually we are, like when we do the coding, we manually place the electrode position. It takes an account of all these things and then generate the E field for that.
But there's no like tractography information.
No, there's no tractography. So we just took a T1 weight for generating an E field simulation for this. We just need a T1 weighted image. So it gives after doing the segmentation, the particular how much CSF value is there, how much the brain gray matter and white matter is there. So it gives, it already has, like, already calculates the conductivity according to the matter that is there and then gives a E field. So we didn't do the tractography for this.
Yeah, do you think that will add value to it? Because I just attended a talk earlier that they showed that white matter architecture can like guide the propagation of direct current, like something like that.
I think so.
Okay.
Right now, what we are doing is that definitely we are taking DTI, like we are doing DTI for these atrophy patients and all, and seeing whether there is an effect of all those tractography and all those things that currently we are doing right now.
I just had a quick question. I mean, in some of the plots that you showed there, the histograms, you see quite significant variation across your individuals. And I think that's an issue that we see across brain stimulation paradigms, individual heterogeneity. Do you have some sense about what the drivers are of that considerable variance or heterogeneity in response? I think you spoke about atrophy, but are there any other factors that might explain or underlie or drive that considerable variance in the responses that you showed?
You mean any physiological aspect that can also affect it?
Correct, yeah.
This is something, again, it's something we are taking consideration if there is any heart rate variabilities and all other parameters whether they have any effect on these things. So right now we are doing a clinical trial on this, as well as evaluating other pathophysiological, other physiological aspects. So whether they also have any effect on that or not.
Yeah. We'll have to wait for your future work before we know.
Maybe next OHBM I can be presenting those results.
Yeah, we'll look forward to it.
Yeah.
Thank you very much. We've got one more quick question.
Sorry. So I just want to know how you define the electrode placement of the high definition TDCS. Like there's a way to optimize the electrode. And have you used that, or did you just follow the previous conventions?
Yeah, so there are some papers from Bixen's papers, Alam's papers. They have already extensively worked on how much diameter is suitable for HD-tDCS and where it should be placed and all those things. So we took in consideration, we took those references for placing these electrode for HD. So yeah.
Okay, I understand.
Thank you.
Hi. It was a good session.
Thank you.
So I just want to know, like, what was the whole duration, the stimulation paradigm?
We didn't do stimulation. This was a simulation protocol, but usually 20 minutes is the basic time period if you're doing a stimulation. That's ideal for TDCS.
So in your experiment, you did not do stimulation yourself?
Yeah, this is only simulation results. So right now we are working, I just said that clinical trials we are doing so that we can replicate the simulation results in some behavior results and all those things. And till now, it's going great.
Okay, good luck.
Thank you so much.
Okay, so please join me in thanking Irtisha again, and